In my last video, we talked about the functional shoulder anatomy, some of the biomechanics. In this video, we're going to focus on some of the interesting pathologies of the shoulder that I see in the clinic a lot and different type of strategies we want to do to address them. Now, one of the important things to remember about the rotator cuff, even though it's four muscles inserting onto the humerus, it's not four different tendons that have all their different attachment points. Think of the rotator cuff as this blended tendons that insert all around the humerus. So yes, four muscles do come in with their tendons, but then they blend together around the insertion. It's kind of like a sock on your foot. So if you have any injury to the tendon, it's more like there's a hole in the sock as opposed to one of the tendons is frying away. One of the most common injuries I see is rotator cuff tendonitis. Now, we no longer call it tendonitis because there actually is no signs of inflammation. There's not like this redness or this heat or this swelling. It's more appropriately coined tendinopathy, which really just means that at the tendon there's some cellular level degeneration that has a greater rate than the regeneration of the tendon. So you get kind of stuck in this chronic state of pain and discomfort and limited use that further feeds into that cycle of greater degeneration compared to regeneration. Now, what it is from an overuse injury. So I most typically see this in adults who are not used to doing a certain activity and then all of a sudden pick up an activity. For example, over the winter months, not doing much of their arms, kind of more that hibernating state. And then spring and summer come around and what they're doing, they're gardening, right? They spend 10 hours a day doing all their gardening and pruning, doing the hedges. They're painting their walls, they're washing their windows. They're doing all these overhead activities for hours on end after taking months off during the winter, not training their shoulders. That's one of the most common ways I see this rotator cuff tendinopathy come in. Now, pain for rotator cuff tendinopathy is often in the supraspinatus, kind of feeling it into the front part of the shoulders. You will also have sometimes some biceps long head tendinopathy. Now that's because most people are stronger in their elbow flexors than they are in their rotator cuff and overhead muscles. So when they are doing these things overhead, they're recruiting the biceps with that little tendon insertion into the joint to help stabilize the arm and use it in those positions. So those two I kind of find go hand in hand. Of course, you can get overused to the other muscles as well, depending on what position you're doing it. But overall, it's the deconditioning from not doing things for a long period of time, and then the history of all of a sudden picking up some overused thing. Now, other injuries to the shoulder are kind of your trauma ones, such as when you fall and land on your shoulder and you kind of crush or strain the ligaments and the joint, and the muscles are strained as well. One of the most common crush or traumatic ones is the AC joint. So whenever you kind of get the history of someone playing rugby or they're bike riding and they fall onto their shoulder, usually it's the AC joint that takes the brunt of that trauma. Of course, the muscles as well as they stabilize the arm. With the overhead falls, that's where you're more looking into subluxations and dislocations, because then the humerus may leave the glenoid fossa and stretch out the joint capsule. All of these injuries kind of take the same approach. What you're trying to do first is gradually increase the range of motion, trying to gain that mobility back, resisted isometrics to maintain the function of the muscles as best you can, and then go through progressive loading. Tendons need loading, muscles need loading, everything needs loading to adapt to get back to where you were. Now, all of these injuries have different timelines and different specifications on irritability, but overall, you're trying to gradually progress range of motion, maintain muscular function, and then increase loading for adaptation. That's the formula you follow for all these injuries. So an AC joint injury has actually six stages, and usually at grade 2 to 3, you'll start to see a step deformity. So where the clavicular where the clavicle attaches to the acromion, there's a bit of a step deformity because the acromioclavicular ligaments has been torn. Now this is usually the last stage before they start to kind of consult for surgery. However, I've had a grade 5 AC joint separation where there was no surgery, and it was a pretty good rehab, but it was quite interesting. All the ligaments were torn. Now with an overhead subluxation or dislocation, or just kind of like a posterior inferior mechanism, What we have to be really mindful of is that all those tendons and ligaments are stretched, the joint's capsule is stretched due to the amount of force needed to sublux or dislocate the joint. So when we're trying to gradually improve our range of motion, we're not actually trying to push them too far, because we do want the muscles to tighten up again to let everything settle. So some nice resisted isometrics are really important in this stage as well to help with appropriate healing while regaining that comfort and achieving our full mobility. The overall theme with all the shoulder injuries is that they can be quite painful and limiting in your ADLs, your activities, and your function. And it's really important to know your pain barriers and your pain threshold. That pain is just a warning sign, and that we have to do some of this loading and exercise. Now, the difference with strains of the muscles in the shoulder is you'll be feeling them in the actual muscle bellies where they are up and around the shoulder blade. And then often the tendinopathies, you'll be feeling them into the actual humerus area. So that's kind of how you can distinguish, is it a muscular strain versus a tendinopathy. Does it really make a difference? No, because we're still going to follow the same formula: gradually progress range of motion, maintain tissue health, and then increase tissue loading to regain full function. Thanks for watching. Please like and subscribe, and leave a comment below of something that you'd be interested to see next. Tune in next time.